All right, in this video, we're going to go over a diagnostic sacroiliac joint injection, otherwise known as an SIJ injection. All right, these are some of the things you'll need. First of all, you'll need a Mayo stand, and then a sterile drape, surgical scrub prep, a 18 1.5-inch hypodermic needle for drawing up medication. That's also useful for indicating where you intend to inject on the patient. A 5cc syringe for skin infiltration with a 1.5-inch 25-gauge hypodermic needle for skin infiltration. A 3cc syringe for contrast. A 25 or 22-gauge 3.5-inch spinal needle or Quincke needle. And a 3cc syringe for your inject date. So I'll caveat this video by saying there are many ways to do an SI joint injection. This is just one of them. In this video, we will be aiming to make the inferior 1/3 or the caudalmost 1/3 of the joint as maximally crisp and radiolucent as possible. So we'll go ahead and take an AP image now. We have our AP image now, and I just want to add that prior to doing so, make sure to clean the patient, and I try to have some towels over the behind of the patient. This is a rather exposed procedure. Make sure you warn patients ahead of the procedure that how much of their pants will be pulled down so that you give them that heads up, and then you'll have a sterile field. So now we will optimize that inferior 1/3 of that caudal 1/3 of the joint. All right, let's bring it all together and do it live. Let's do it live! For objects that are superimposed when you're taking fluoroscopic photos, like the anterior and posterior joint margins of the SI joint can be, the most superficial or the image or object closest to the image intensifier, so the top of the C-arm, will move in the opposite direction as you are obliquing. So in this case, the posterior margin of the SI joint should be moving to the right while we oblique the C-arm to the left. We've made the inferior 1/3 of the joint pretty crisp. So now we'll aim for 1 to 2 centimeters above that area and then infiltrate the skin with some local anesthetic. So I'll put down my marker and then take an image to see where I am. You can now see the tip of the 1.5 25-gauge hypodermic needle laying over the inferior aspect of the sacroiliac joint. Great, that looks good. So we'll go ahead and infiltrate the skin with some local anesthetic and proceed with the injection. So the skin's numb, so next we'll proceed with a 22-gauge 3.5-inch spinal needle or Quincke needle. And we've left the local skin infiltrate needle in just to mark our area. Next, we'll advance until we hit the joint space, or if we hit os, we'll reposition our needle and attempt to enter into the joint. So now we have a coaxial or barrel view of our needle going into the joint. Ideally, you should sort of bias medially such that you can slip into the posterior aspect of the SI joint. So I've just hit that gummy consistency or that rubbery consistency, which is the posterior ligament of the sacroiliac joint. At this point, we'll check the depth of our injection. We have a lateral view of the SI joint now. This can be a little bit confusing because it is a very irregular shape, but you see our needle here, and it is entering in probably out right here where the joint, or at least the synovial or the articular aspect of the joint would be. So remember, it's irregular shape, which, is in reference to its ear-like, L-like shape. So it would probably look something like this if we were to inject contrast. We rotated the C-arm for a lateral image to check the depth of our needle and to make sure that we're in the joint. At this point, we'll inject some contrast, check a lateral view, and then a contralateral or an AP view as well. Okay, we've taken another contralateral oblique view and another lateral view after having injected contrast. I don't actually have contrast, and you can't inject contrast into this mannequin or model. But the main thing is you're looking for spread within the joint lines and not extravasation, so contrast spread outside of the joint lines. In order to really evaluate contrast spread, you actually need photos of it. So I'll skip that point for now. And then hopefully in some point in the future, I can have photos that would, show optimal contrast spread in the SI joint and other injections, for instance. Okay, we've injected contrast. We've checked multiple views. We don't see an extravasation, and we're happy with our contrast spread. At this point, we can go ahead and inject our injectate. So that's not going to be more than usually 2 to 2.5 cc's of injectate. And just to give you another view here, we have our needle going to the SI joint. And if we peel back the skin, not real skin, but and then actually look at where this needle is going, you can see multiple trajectories already taking place right into the SI joint right here. One last thing is that some practitioners use a little bit of cephalad, so towards the head tilt of the II, the image intensifier. So now the C-arm is actually tilted towards us, towards the head, and we'll take a look at what that looks like on the fluoro images. With the cephalad tilt, the posterior margin of the sacroiliac joint becomes a little bit longer. It lengthens the posterior element. So some practitioners prefer this because it can make it a little bit easier to see.